So the title of the study that I'm going to be talking today is the BC Fentanyl Cohort Study. And as Lily mentioned, the co-PIs of this study are Doctors Michael Kraus and Martha Ignachevsky. And we've been officially recruiting for the past year since February of 2023. And we recruit here at Vancouver General Hospital as well as Anne Vogel Clinic in Richmond. And the nature of the study is that it's a cross-sectional cohort study of people who use fentanyl as their primary drug of choice. And we've recruited 220 participants so far. And that is the number that I'm going to be discussing when it comes to our findings. So to talk a bit about the agenda for today, I'm going to give a bit of background about BC's current state in terms of the opioid crisis, some of the methodology that we used for our study, some of our findings, and ultimately tie this back to translational research in theme with this cluster. So to first give an intro in terms of the opioid crisis, we know that since 2014, Canada has experienced a significant shift in the drug market, with synthetic opioids, particularly fentanyl, becoming dominant. And the impact this has had is that opioid use patterns and health consequences have seen significant changes, and it's ultimately resulted, it's been a big role in the 2,511 overdose deaths we saw in 2023, which necessitates a reevaluation of substance use, disorder care, and current practices and policies that are in place. So I'm going to talk about the aims of the study shortly, but a general goal for the study is to get a good understanding of people's experiences with the healthcare system and with other systems of care as well, and to kind of foreground this discussion and highlight some of the ways that traditional approaches to opioid use fall short. We can look at opioid agonist therapy, which is a very effective and common practice in treating opioid use disorder. But Canada faces disparities in OAT coverage and low retention rates, which pose challenges in mitigating the harms associated with opioid use. Similarly, with detoxification programs, there's high dropout rates and low completion rates, which highlight the need for comprehensive and adaptable strategies as well. And finally, with accessibility, geographical barriers, stigma, and limited harm reduction tools compound the need for more strategies to mitigate this issue. So there's also the harm reduction model in Canada, which is mainly safe injection and safe supply. And this is a largely effective practice, but it's still worthwhile to evaluate the effectiveness and maybe compare it to international practices and just gain a general sense of people's lived experience with these programs as well. So ultimately, to address the synthetic opioid crisis, it requires comprehensive strategies to improve access, retention, and effectiveness of treatment, and ultimately to establish continuums of care and multifaceted support for people who need it. Obviously, this is all with aims to combat the devastating impact of the synthetic opioids on public health and well-being. So now on this slide, some of the research objectives and aims. The four ones that I have highlighted on this slide are to, one, document changing patterns of use and routes of administration and their correlation with fentanyl use. Secondly, is to analyze risk and protective factors for increased mortality and lower survival rates amongst people who use fentanyl as their primary drug of choice. To analyze people who use drugs as response, engagement, and interest with the current systems of care and what their expectations are for the future in response to the overdose threat. And finally, to study which models of care are most effective at keeping people safe after experiencing a non-fatal overdose. All these aims are ultimately working to inform healthcare system development and really optimize treatment and care. So next slide, please, Lily. Thank you. So now to talk a bit about the methodology. This questionnaire was developed through expert consensus, and we really took an iterative and developmental approach to creating it. But essentially, the topics covered, the survey really prompts a whole range of information. Just to list some, it covers sociodemographic information, fentanyl use and history, patients' experiences and opinions related to the systems of care and safe supply, overdose experiences, risk management and practices, mental and physical health, and childhood trauma administered through the Adverse Childhood Experiences Questionnaire, and that's called the ACE questionnaire. And that asks about neglect, abuse, and household dysfunction that might have occurred before the ages of 18 for folks. To talk about the recruitment sites, as I mentioned, we recruit here at VGH, and that's where the majority of our recruitment has happened in the last year. But in the past month, we've actually expanded to Ann Vogel Clinic. And VGH patients here are receiving acute care in hospital, whereas Ann Vogel is a primary care practice that has services for individuals specifically with opioid dependence enrichment, and it's a team of doctors, social workers, and addiction counselors working there. So to talk a bit about our recruitment methods, participants were recruited by convenient sampling with the Complex Pain and Addiction Services referral team here at VGH. And in brief, patients with opioid use disorder diagnosis and self-reported use of fentanyl, illicit fentanyl in the past 6 months were consented by the CPAS staff and referred to the research assistant, myself, and a team of volunteers. We went and we met with the patients and initiated the survey during their hospitalization. So questions were hosted by a Qualtrics software, verbally with the research assistant and the patients, and respondents answered. The duration of the survey really varied based from patient to patient, but it took an average of 30 to 60 minutes. And at the end, patients received an honorarium for their time. And I really want to highlight the ways that collaboration really was a big part of this process from the very start until now, all stages, from like creating the survey to implementing it to analyzing the results. As I mentioned earlier, we work with a team of 12 volunteer research assistants and myself at VGH, and we're constantly working collaboratively with the healthcare team and the nursing team to, for example, see if patients are in a safe space psychologically to do the survey, if they're agreeable to it, if they have any needs that we should be aware of when we're doing the survey. And also, it was really important to establish a clear line of communication with the healthcare team to make sure that the survey wasn't interfering with the patient's healthcare plan in any way and trying to be proactive in doing the survey. Yes, Dr. John. With the patients, yeah, I think the conversations that we have are really quite sensitive. I mean, as I mentioned, the survey covers information that can be really hard to talk about. And sometimes finding a good way to make the patient feel as comfortable as possible throughout this process was really helpful in getting them to feel safe to open up. And so throughout the survey, the volunteers and I, we really prompt the patients and we gauge how we really try to prepare them for the questions that we're about to ask. So we make sure that they're aware that all the questions are voluntary and that they're anonymous. But beyond that, we try to explain how sometimes it might be hard to talk about. And if they do share something with us, we thank them and we show appreciation towards doing that. And yeah, sometimes patients have communication needs that come up. And trying to find a way to optimize the communication between us would be also a collaborative process as well. Yeah. Great. Okay, so now that we've covered the methodology, we can get into the findings. So this slide highlights some of the sociodemographics of our cohort. So the majority of them are male, with 66% being male. 58% of participants are white, and 26% are Indigenous. 16% are from other ethnicities. The mean age is 43 years old. 56% of participants have completed high school, and some have gone on to do postgraduate studies as well. In terms of housing, 55% of participants have unstable housing, and that's defined as living in a SRO, a shelter, on the street, couch surfing, etc. And 54% of participants are dissatisfied or very dissatisfied with their housing situation. And finally, 17% of the participants were employed for wages, and the remainder of them were either unemployed and looking for work, or not looking for work, or they were on disability, pension, or self-employed. Thanks, Lily. Yeah, go ahead. Yeah, it's self-declared. We asked them how they identify. Yeah, the sample size is 220. Yeah, great. So to talk about the clinical characteristics, these are just a few that I pulled that I found to be interesting, but 77% of the participants were diagnosed with mental illness. 57% expressed suicidal ideation over the past 6 months. 38% received medication for mental illness over the past 6 months, and 18% received psychotherapy for their mental illness over the past 6 months. So that was all the mental health. And relating to their physical health, 74% of participants experienced chronic pain over the past 6 months. And we know that chronic pain is largely correlated with opioid use. And we actually prompt the participants to explain how this might correlate for them. A lot of people say that they use fentanyl to self-medicate for their chronic pain. Other people have had the experience where they've had a prescription from a physician, but they've lost it and can no longer access it. Also, some participants find that the physicians that are prescribing their medication, it's not strong enough to adequately treat their pain. So they kind of have to compound that with illicit opioid use as well. And this is a big topic of discussion when it comes to opioid use, how chronic pain can be best managed. Thanks, Lily. So this slide is some of our findings related to harm reduction. So the first stat is about naloxone, and 72% of our participants reported that they carry naloxone with them, which is great. But for harm supplies other than naloxone, such as syringes, dairy cups, cookers, 21% of participants engage with this practice. 17% get their drugs tested with test strips, and 12% get them tested with a spectrometer. And then 30% of them go to supervised consumption sites such as Insight in the downtown east side or the Overdose Prevention Society. And 58% are using with friends or others around them. But that means that 42% are using alone, which is a major risk factor with fatal overdoses. And another point of our research is kind of investigating the way that social isolation and social disintegration can result in higher risks when it comes to using opioids. So that's something that we're trying to learn more about as well. Great, so this slide is on the routes of administration for fentanyl use in particular. So the vast majority of participants are smoking fentanyl, so 72%, and 8% are injecting it. 19% are doing both. They're both smoking and injecting, and 1% are either taking it orally with pills or snorting it. But we can see that smoking definitely is the most popular route of administration. And in discussion with participants, it's perceived to be less risky in terms of overdosing. But in conversations that I've had with clinicians, such as Dr. Ignachevsky, she's mentioned that this isn't the case. The risks are just as high if they were smoking versus other means. And so there's a perceived discrepancy there. So this slide highlights the incidences of overdose. So 82% of our participants have experienced an overdose. And here I have the mean and the median overdoses. So the mean is 14.6, and the median is 5, and the standard deviation is actually 30.7, with the interquartile range being 13. And the reason why the deviation is so great is because there's actually such a big range of overdose incidents. So a lot of people have overdosed 1, 2, 3, a couple times, but there's also people on the opposite extreme of the spectrum who overdosed 100 times, 200 times, 300 times. So there's such a broad range of this experience. And another aspect of the study that I'm looking to learn about is doing a cluster analysis of these extreme groups and to look at what kind of practices are common for people who are lower risk and have less experiences with overdose versus those who are on the extreme end. So that's something that we're looking to learn more about as well. So now to talk about opioid agonist treatment. These are some of the most common therapies, and Suboxone is definitely the most popular treatment at 64% of our participants having experienced it. 41 have used methadone before, 15% have used Cadian, 5% have used injectable opioid agonist therapy, and 8% have tried Sublocade before. And on the next slide, we talk about detox and safe supply. So 41% of participants have completed detox at a hospital or at a clinic. 41% are prescribed hydromorphone, which is also known as Dilaudid, which is a part of the Safe Supply Initiative. 7% have used Meslon, which is the morphine derivative. 6% have used the fentanyl patch, and 6% were actually unaware of what the Safe Supply Initiative is and have never heard about it before. Okay, so I've talked about some of the the prevalences of experiences that people have had with their treatment and their physical health and their mental health, but the survey also prompts a lot of qualitative aspects of people's experiences. We ask a lot of open-ended questions to get an idea of what their lived experience has been like. And I personally find that this is a very rich way to gain information and understanding of people's experience with the healthcare system. So the word cloud here is just I guess it's people's experiences with what the government can do the question is, what do you think the government can do to address the opioid crisis? And I thought it would be really nice for me to share some of these specific answers that people have shared with us. And so on the next slide, there's quite a few quotes, but this question here is asking, if you could decide, would you choose to go to a hospital after an overdose? Why or why not? And all of these quotes are kind of on the no side. And I think they highlight really nicely what some of the barriers are for people within the healthcare system, in the hospital setting in particular. So to read them off, the first one says, no, I would rather listen to nurses that knew what to do at a safe injection site. No, because stuff like this happens. You get locked up in the hospital and forced into rehab. No, because they're rude to junkies. What's the point? It's a waste of resources. I don't like being here. I feel like I'm wasting resources. Going to the hospital wastes time. No, because there's a lot of sitting around and waiting to be seen by the doctor. And the last one's quite long, but I thought it was really interesting. It says, usually I don't want to go to the hospital. It's a waste of time. I think that they don't realize is for drug addicts, you come to face your own mortality. You know, it's a game of Russian roulette type game that you're playing, and you have to let go of your own life if you continue to use drugs and say, if I have to die, I die, if I'm not going to quit. And there's many increments where people reach a new low and quit, and then you get long-term users, and they don't care about their own life. They don't care about anything. They just want drugs. And after enough time, it's not even the person talking, it's the drug talking. So that's one of the questions. A lot of people also, when answering this question, they did say, yes, I would go to the hospital after experiencing an overdose. And the main reason is they just want to be safe to make sure that everything's smooth. But I think it's interesting to look into what the barriers are for many people. Okay, so this question here, I touched on this before, but the question is, do you have any ideas or suggestions about what the government should be doing relating to the 2,000 plus deaths from the opioid overdose crisis in 2022? And this is the final question of our questionnaire, and I think it's a very daunting question. It's asking a lot of the participants, and many of them say that they have no idea what the government should be doing, which is quite fair. But these three responses, I think, highlight different takes that are very valuable to acknowledge. So the first suggestion is to have quicker access to detox and treatment. The wait times are really preventing people from getting the care they need. It's a life or death situation. If they can't get it right when they need it, they could be going out the same day and overdosing. Next, safe supply. I'm a hardcore advocate of this. Drugs are so cheap to manufacture, especially for Canada, where we source the largest bulk. I look at it this way, the cost to society of keeping the current system versus cost of introducing safe supply. On one hand, even children can buy hardcore drugs and it's funding organized crime, and these people go and spend it on organized crime. If you want to cut the organized crime, you give them access to safe supply drugs. Stop funding organized crime. Simple. It's not simple. For some of the older people, it's hard to accept that you can give people drugs and they're not bad people. Safe supply saves lives. Do you think people really want to be using drugs? For most people I know, they honestly don't. So many people I know are so abused and come from such troubled backgrounds, and they just want to feel some type of relief. It's a real problem to try and think that you can just solve these people's issues in 1 or 2 steps of therapy. And finally, the last question, I think this one relates really nicely to aspects of care outside of the healthcare system, different social determinants of health, like living and housing and food accessibility. It's really important and it's often overlooked, but this says that they're doing everything wrong. It has to happen in the community, socially, with people not disbanding people for being in that lifestyle, because that's just pushing them away. To heal, they have to feel loved and cared for and wanted, and they're doing the exact opposite. There needs to be systems put in place to help people in their homes take care of themselves physically, like food or cleaning. So yeah, those are some of the quotes that I pulled, and I think it gives us a good insight as to what people perceive their own experiences to be and what their needs are, which is very valuable to hear about. Great. So to kind of wrap up the discussion and tie it back to translational research, we know that translational research plays a crucial role in addressing complex public health challenges like the fentanyl crisis that we see here in BC. And so by translating scientific knowledge and lived experiences into practical solutions, we can work to improve outcomes for individuals affected by substance use and reduce the burden of the overdose mortalities that we see. So collaboration across disciplines and sectors is essential to ensure that research findings are effectively translated into policy and practice. And to kind of tie back the aims that I touched on in the beginning of our talk, in terms of translation. So our aims were to gain insights into motivations behind fentanyl use and its impact on physical and mental health, evaluating the effectiveness of interventions such as opioid agonist therapy, safe supply, mental health support in real-world settings, to identify what barriers there are for people for the uptake of evidence-based practices and developing strategies to overcome them, and ultimately to inform policy decisions related to harm reduction, access to treatment, and stigma reduction. So, to close, what we hope to do in action with our aims is to develop evidence-based interventions, so tailoring treatment approaches based on patients' needs and preferences as we hear it from them, integrating services, so coordinating care across healthcare settings to provide a comprehensive approach for people who use drugs, training and education, equipping healthcare providers with the knowledge and skills and tools such as the fentanyl cohort study that we hope to expand across the country to deliver effective care and to reduce stigma, and ultimately advocacy and policy change. So mobilizing stakeholders to advocate for policies that promote harm reduction, treatment access, and support for individuals with substance use disorders in a very holistic way. So that is my presentation. Thank you for listening, and I'll take any questions.